Welcome to the deep dive. Today we're tackling gout, but maybe not the way you think about it.
Right. Most people hear gout and immediately picture, that sudden awful pain, often in the big toe.
Exactly, that classic acute attack. But the sources we've gathered paint a very different picture. It's less an event, more a chronic condition.
Precisely. It's fundamentally a progressive systemic metabolic disorder. The real issue is hyperuricemia, having too much uric acid, or UA, in your system.
Okay, hyperuricemia.
Yeah, and that high level causes these tiny monosodium urate crystals, MSU crystals, to deposit throughout the body. The flare is just the symptom you notice.
So this challenges the old idea of, I just ate too much rich food.
Yeah.
Our sources point much more towards genetics, right?
Absolutely. For most people, the problem isn't really making too much uric acid. It's that their kidneys struggle to get rid of it efficiently. Impaired excretion.
Impaired excretion.
Yeah.
Because of specific genes.
That's the key finding. Genes like ABCG22 and CYFLC2, AI999 are often involved. Think of them as gatekeepers for urate removal. If those aren't working optimally, well, diet can make it worse, but the underlying tendency is already there.
Okay, the genetic link is crucial. So given that tendency, how does gout typically progress? Is it just random attacks?
No, there's a pattern. It often starts as asymptomatic hyperuricemia, high UA, but no symptoms yet.
Then comes the acute attack we mentioned.
Right. But the really critical phase, the one we need to focus on, is what comes after the attack. Intercritical gout.
Intercritical.
Yeah.
Meaning between attacks, this is where the silent damage happens.
Exactly that. You feel fine, the pain's gone, so you think, problem solved, but it's not.
No.
Those MSU crystals are still present. They're continuously, quietly damaging joints, ligaments, tendons, and importantly, the kidneys.
So ignoring it during this phase is really dangerous.
It's what allows the condition to progress to the really severe stage, chronic tophaceous gout, where you get those large, visible crystal deposits called tophi.
Wow. Okay, so diagnosis then. If the UA levels in the blood can actually drop during a flare, how do you diagnose it for sure? A blood test seems unreliable at that point.
It can be very misleading. Serum UA might look normal or even low because all the urate has rushed into the joint, causing the inflammation.
So what's the definitive test?
The gold standard is synovial fluid analysis. You have to actually draw fluid from the affected joint and look under a microscope for those specific needle-shaped MSU crystals.
See the crystals themselves, that makes sense.
Gout is defined by the crystals, not just the UA level at one point in time.
Right. So if the core problem is this crystal accumulation, the treatment goal must be getting rid of them, dissolving them.
Exactly. Continuous uric acid lowering therapy, or UAL. You need to lower the serum UA level consistently below the point where crystals can form or stay stable.
And there's a specific target number for that.
Yes, the widely accepted target is getting and keeping serum UA levels at or below 387 micromoles per liter. That's 6.5 milligrams per deciliter in the U.S.
6.5. Yeah.
Staying below that threshold allows those existing crystals to slowly dissolve over time. It's a long-term strategy.
And the usual first step for medication is allopurinol.
Allopurinol is the typical first-line UAL drug, yes. It works by inhibiting an enzyme called xanthine oxidase, which reduces how much uric acid your body produces.
But starting, it can sometimes stir things up, cause another flare.
That's a key point. It's called a mobilization flare. When you start dissolving those crystals, it can actually provoke an inflammatory response. It feels like another gout attack.
Ouch. So how do you manage that? People might stop taking the drug.
Right. Adherence is key. So to prevent these flares and keep people on therapy, UAL is almost always started with a prophylactic low dose of colchicine, usually 0.6 milligrams daily.
For how long?
Typically, for the first 6 months of UAL therapy, it helps calm things down while the body adjusts and the crystals start dissolving.
Okay, this is all crucial for managing the gout itself. But the sources also highlighted a really significant connection to broader health issues.
Oh, absolutely. This is maybe one of the most important takeaways. Gout isn't just about your joints. It's often an early warning sign for metabolic syndrome and cardiovascular disease.
So things like high blood pressure, diabetes risk, heart problems.
Exactly. Having gout significantly increases your risk for those conditions. And some research even suggests the high uric acid itself might not just be a marker, but could actively contribute to the development of METs and CVD.
Wow. So treating the gout effectively, getting that UA level down, might actually help reduce those bigger cardiometabolic risks too.
That's the implication, and it's a really active area of research. It means managing gout is potentially about protecting your heart and metabolic health long-term, not just preventing joint pain.
That's a huge perspective shift. Okay, let's quickly touch on diet, because there's some nuance there. What are the definite things to avoid or limit?
Well, the classic ones hold true. Organ meats like liver, certain high purine seafood like anchovies and sardines, alcohol is a big one, especially beer and spirits.
And something maybe less obvious.
High fructose corn syrup. It's in so many processed foods and drinks. The problem is that fructose actually messes with the kidney's ability to excrete uric acid. It directly counteracts what you're trying to achieve,
Making the underlying excretion problem worse. Got it. Now let's bust a myth. What about vegetables high in purines like spinach or asparagus? The old advice was to avoid them.
Yeah, that advice is outdated. The evidence is pretty clear now. High purine vegetables do not increase gout risk or flares. You absolutely do not need to restrict them. They're healthy foods.
That's great news. Anything people should try to include.
Yes. Low-fat dairy products seem to be protective, helping lower UA levels. And cherries, or cherry extract, have also shown benefits in reducing flare frequency for some people.
Interesting. Okay, so wrapping this up, the big picture is gout equals crystal accumulation. It needs long-term metabolic management with UAL therapy to dissolve those crystals. It's not just about chasing the pain of flares.
Exactly. The focus has to shift from just treating the acute symptom to managing the underlying chronic metabolic condition.
And given that potential link we discussed, where hyperuricemia might actively drive metabolic syndrome, it leaves us with a final thought for you, the listener.
Right. Even if you've never had a gout flare, what might a routine check of your uric acid level tell you about your deeper, long-term metabolic health and maybe even your cardiovascular risk? It's something worth considering, perhaps discussing with your doctor.